All right, so let's shift gears and move, although I am going to come back to PE shortly. What I want to talk about now is the crashing patient or the pre-crash. Let me again say that I started out in internal medicine and had great trouble. I was actually cruising along in my third year, and then they mentioned there was a board exam, which I had no idea about, and then there was an entire textbook. And so although eventually I did pass the boards first time, I figured I had to go into a specialty that we embrace, and one that's very simple. And so this is what I know about emergency medicine. ABCs, airway, breathing, cardiovascular stability, every time, every patient, unless they're DNR, there's an advanced directive. And we switch things around. I mean, it always used to be airway, then breathing, then cardiovascular. And now, cardiovascular, you can just shock them. You don't even have to breathe them. If a patient has alterations in mental status, NGT, which is not NG2, but naloxone, consider it. Glucose, consider it. Thiamine, consider it. And Jim Roberts gave a great case, and unfortunately many of us have histories of a crashing patient, and if only we checked the glucose to start, not when somebody pointed it out. And finally, because it is too hard to remember too many things, in general, both when learning new material or in an emergency, it's hard to have more than 5 steps, 5 reasons, 5 causes. And so, and that goes for, even if you look at an international grand chess master, if you say like knight to queen's bishop 3, although he or she might be thinking 35 moves ahead, they have broken it up into moves of 3, 4, 5 at a time, sequences. If I asked your phone number, which I did not, you'd do 1, then 3 digits, then 3 digits, then 4 digits. We break things up. So whenever I can, 5 causes, 5 steps. A patient presents with wheezing. There are only 5 causes of shortness of breath, and I have up there the 5 causes of wheezing. That's all there is. My wife is in pulmonary critical care. Things like this can cause a night sleeping in another room, but there are only 5 causes. Reactive airway disease, which you can include a lot of things in. People that have heart failure, all that wheezes is not asthma. Pulmonary embolus, new wheezing, unilateral wheezing, could be a foreign body, could be a pulmonary embolus. Pneumothorax, and then finally a mass that you can see either on chest x-ray, on CT scan, or it's really a mass and you can see it with your eyes like a peanut or a denture. So I want to talk about a couple of emergencies. Start that clock. It says I have 0, and it means I really have to rush, or that I have all day. Okay, so whenever I see a severe asthmatic, I don't think which drugs, I just think 5. They get started on oxygen, they get an inhaled beta agonist along with an inhaled cholinergic, pediatric or adult. Although the anticholinergics in asthma do not work in everyone, in about 1 in 5 people, they'll increase the FEV1 by anywhere from 10 to 20%. Essentially no cost, it lasts forever. So O2, beta agonist, anticholinergic. Next, steroids. Steroids are going to take a bunch of hours to work. If they're sick enough to come to the ED, they're sick enough to get the steroids. Doesn't have to be IV, can be oral. In general, sick patients are going to get IV. And then finally, magnesium. Magnesium only works best in the worst patients. It has no effect in mild to moderate asthma, but just like anticholinergics, it improves FEV1 by 10 to 20% acutely. In the very worst, the bottom quartile of patients, and it opens up the airways. It actually paralyzes them a little bit so that the beta agonist and anticholinergic can get right down. Okay, so you've done those 5 things. The patient is worsening. What next? Okay, next patient. Anaphylaxis. Don't worry, we'll come back. Anaphylaxis, an emergency's emergency is anaphylaxis. You get stung by a bee and it gets red and it hurts. It's called a bee sting. You get stung by a bee and you get red, or the patient gets red, systemically, a systemic reaction to an allergen, anaphylaxis. About 90% are going to have wheezing, 10% don't. 5 drugs. The key drug, epinephrine. The only proven drug in anaphylaxis is epi. Between 25 and 40% of people with anaphylaxis don't get it. The number 1 cause of death in anaphylaxis is the failure of 1 of 5 people to administer epinephrine in a timely fashion. The patient, family, paramedic, nurse, or doctor. Number 1 cause of death. Keep that in mind when you withhold the epi. Benadryl. There is no proven data on Benadryl in anaphylaxis except give it, Please be aware, though, that more than 25 milligrams is going to get you off in a consult with Jim Roberts or one of his tox people. There's no data to show that more than 25 works, although it does make people sleepy. By the way, I'm a little self-conscious. There are no penis pictures in this talk, and after Jim's talk, I don't feel good about that. I was embarrassed. I didn't realize that putting a rubber band around your penis could cause local trauma. I knew you could blow both your eardrums out, but I guess that's a whole nother talk. H2 blockers are synergistic with Benadryl, the H1 blocker, blocks bradykinin, decreases edema. H1, Benadryl. Give the H2 also. Steroids, get them on board. It's going to decrease second wave phenomena. Somewhere around 5-7% of people have a second wave. 4 to 6 hours later, this will block it. And then something that a lot of us don't do, and it's not just there so that they're 5, volume. There are many reports of patients who have a systemic anaphylactic reaction who do great. Epi, H1, H2, steroids, 20, 30 minutes later, they are dramatically better. They want to get up to pee, they fall, they hit their head, they break their nose. There have been EMD PEA arrests. People are vasodilated with anaphylaxis. Let them stay in bed longer, tank them up 1 or 2 liters in young, healthy people. The patient is worsening. What next? So we have 2 rooms. We've got the status asthmaticus that's getting worse, 5 drugs. We got the anaphylaxis getting worse. The drug of choice is sub-Q or IM epi. In asthma, it could be sub-Q or IM. In anaphylaxis, always IM. Deep circulation. The thigh is about 4 to 6 times more better. Is better, the epi more potent quicker, but oftentimes deltoid, especially if you're in a public place or on an airplane and it's anaphylaxis, if you're pulling someone's pants down or pulling someone's skirt up, even if you say, I'm a doctor, it sends the wrong message. Deltoid, people understand the deltoid. There have been a lot of mistakes, though, with epi dosing, and I'm going to talk about that in a minute. So rather than saying 0.3, 1 to 1,000, say 0.3, 1 milligram in 1 cc, so that who's ever working with you, usually the nurse, they know exactly what you're asking for. You're asking for this, 0.3 cc's in an adult. If you can't remember any dosing at all in an emergency, it's always 0.3. If they're superhuman, you could go a little bit higher. If they're a kid, you can, if you're a pediatrician, it's 0.01 milligrams per kilogram, but that's how they make dosing errors. What I do is I say, what percent of an adult is that? And that's the dose they get. They're about half the size of 0.15. That is not the drug, okay? That is cardiac epi. That is for cardiac arrest. After you kill the patient with anaphylaxis, that's your drug. Before, 0.3 IM. Okay, what I want to talk about, so we've done our 5 drugs for anaphylaxis. We've done our 5 drugs for our patient with status asthmaticus. It's a patient with heart block who's not responding to atropine or a transvenous pacer. We want to go to IV epinephrine. It's someone with refractory shock. We want to start IV epinephrine. It is so hard to give intravenous epinephrine. It is safe if you do it right, but here's an article from the Annals of Emergency Medicine. Physicians and paramedics make dosing mistakes in using IM and IV epi, especially when dealing with severe anaphylaxis and asthma. So I would like to go over how to give intravenous epinephrine impeccably well so that you never have to look it up, you never have to call to the pharmacy, which takes 10 minutes and you may not have 10 minutes, and you become an expert. And it's when you can't say to the nurse, the usual dose, start slow, titrate up, because they may not know the usual dose. The starting dose is 1 to 2 mics a minute. You don't have to know that. I'm telling you that so that you know I'm allowed to teach, that therefore I have this slide. I want to teach you the rule of 1 for those of you that don't know it. If you want to give epinephrine the best, and you're not working in an ICU where you routinely give IV epinephrine and you may have some other dosing format, this is the rule of 1. Take 1 milligram, which could be 1 amp, 10 cc's, 1 little ampule, 1 cc, but 1 milligram of epi, or 1 amp or ampule of epi. Put it in 1 liter of fluid, normal saline, and start it at 1 cc a minute. A milligram in a liter at 1 cc a minute. And what you're going to do is you're going to take your 1 milligram and you stick it in a bag. You're going to start this bag at 1 cc a minute. But if you give somebody who's dying fluid at 1 cc a minute, it's going to take about an hour and a half to get into their heart. So you obviously have already started, or should already start, in any person who's in extremis, a liter of saline going, that's going wide open, and you're going to piggyback in the epinephrine into the high-flow IV. What I mean by that is that the epi going slow is going to be put into that river of normal saline going fast, so that the epi, the slow drip of epi at 1 cc a minute, 1 milligram and 1 liter at 1 cc a minute, goes into the fast normal saline mixture, and that gets into the patient. At 1 minute, you look at the patient. If they are not dramatically better, you double the dose. At 2 minutes, or another minute, you can double the dose. In my 25 plus years now, in my professional partners' 25 years, 50 years of working in very large EDs, we've never had anyone go higher than 4 mics in anaphylaxis or asthma. We have had one person that got to 7, but that's because the resident and new attending started at 7, and then we had to back off. But in 2 to 4 minutes, you're going to cure the patient. 1 milligram, 1 liter, 1 cc a minute. The way I look at it is this. If someone is dead or dying, you give IV epi. If they're not dead or dying, if you give IV epi, they will be. So you want to reserve this for really critically ill people. The number one cause of death is the failure to give epi. So IM epi is great in asthma. IM epi is the treatment of choice in anaphylaxis, not Benadryl. Supplement it. But if they're going down the tubes, if they're profoundly hypotensive, if they look like they need to be intubated, you never want to try to intubate status asthmaticus. You never want to try to intubate someone who's in anaphylactic shock. You want to try to bring them back up. That's the rule. Okay, next patient. Pinpoint pupils, hypotensive, bradycardic. What do you think? I'm thinking Narcan. Giddy up. And I give it. Unfortunately, as I've told you, many of my patients do not appreciate how good I am. The patient doesn't respond. So there are 3 causes of pinpoint pupils. Narcotics, unresponsive to narcotics, pontine bleed, and then, as you've seen now, eye drops. Be careful. You know, pinpoint pupils, the big pupils you saw with anticholinergics, pinpoint pupils, be thinking about a cholinergic medication. You can't have 3. And so the other 2, think about organophosphates, salivation, lacrimation, etc. And I'm not sure what rock lava is, but that could happen too. So there's rock lava, and this is a better rock lava. Here, you can see it's only in one color. And what I've done here on this slide, it's now in multiple colors. I think this is a better slide. And this is a nice mnemonic. If you don't like the mnemonic of reserpine, opiates, clonidine, low-modal, ACE inhibitors, valproic acid, valproate, or aldamet, and reserpine and aldamet, not around so much, at least know these 2. For naloxone responsive hypotension, often with pinpoint pupils and often with bradycardia, clonidine, and the best antihypertensive around, not the cheapest, thiazides, but please remember that one of the drugs that so many people are on now, ACE inhibitors. And when you overdose on ACE inhibitors, you look like a narcotic overdose, except 1 or 2 milligrams of Narcan ain't going to cut it. So go ahead and titrate up the naloxone. There was a Harvard study using Narcan in healthy volunteers. They gave 2 milligrams per kilogram to normal healthy volunteers IV. The first patient said he felt a little bit of a rush, so that was the one side effect reported. Narcan in people that don't need it, very, very safe. If you're giving Narcan, something that I didn't appreciate, because I always used to say Narcan has no side effects other than it induces narcotic withdrawal, always turn the patient on their side. Which side? The side facing away from you. Remember, please, or the side facing whoever you don't like, please remember that IV push Narcan in narcotic overdoses has caused a few seizures. If you're giving Narcan, especially high-dose Narcan, 10 or 15 seconds seems to make a difference. Kind of like lidocaine, for those of you that still use lidocaine, not that there's anything wrong with it. Try to give lidocaine, unless it's cardiac arrest, over about 15 seconds. Okay, new patient. Nursing home patient is transferred to the ED for tachycardia. Might be sepsis. The patient is in PSVT, not sepsis, per report with a pulse of 160, blood pressure 90/60. What is the optimal therapy for this crashing patient in PSVT? I know Amal's going to be doing ACLS, but I do a little bit of it too. DC Cardiovert, adenosine. I'll tell you, there's some great diltiazem literature on PSVT. Adenosine does not have to be all and end all drug. What do you all think? What do you like? Adenosine? Anybody for the DILT? Love the DILT. You can titrate it. Cardiovert. You can always tell a great teacher the crowd's really involved. All right, I can't get you to the Cardiovert. There's the PSVT, so you can see it. So Amal showed EKG. See, there's one too. All right, that's a one-lead ECG. If you're only going to do one lead, what should you do? AVR. Beware PSVT in the elderly. Beware PSVT in the elderly. The eye does not see what the mind does not know. Don't assume PSVT is PSVT. You can quote me on that. It might just be sinus tachycardia. And when you see, in quotes, PSVT in the elderly, just be thinking, is this sinus tach in someone who's barely compensated, or have they flipped into PSVT? And so my recommendation is, if you have an older person, especially someone from the nursing home, someone really elderly with PSVT, give them the quick volume challenge of 100 or 200 cc's as fast as it will run in. I didn't say challenge them with 2 liters, because then you don't have to worry about the PSVT anymore, no matter what. Then you don't have to give adenosine, but volume challenge them, and do not follow blood pressure. Blood pressure ain't worth a dick when you're comparing 2 blood pressures over 3 minutes. You know, if you had 5 people take blood pressure on one person, they'll get 10 different pressures. Follow the pulse. Did it move down by 3, 4, or 5? Follow the O2 sat. Did it move up or down? But that pulse is accurate within 1 beat per minute. PSVT doesn't change by a few beats. It either goes down to normal, it goes from 160 to 74, but when you see 160, 158, 157, it's sinus tach. And the reason I tell you this is, I hope this is showing well, but here's someone in PSVT, and then, I don't know how you call that, but I call that asystole. Okay, there's nothing wrong with asystole. Some of my best friends have had it for a while, but you don't want someone who's barely compensated with sinus tach to have asystole, because then they have permanent asystole. In a large study done at one of the largest cemeteries, 100% of dead people have asystole. It is not a good long-term rhythm. Couple of seconds, I could have that, but long-term, not good. So, there are 5 contraindications to the benign drug adenosine, which is a great drug. Number 1, if someone has a rate of 150 or less, 150, assume atrial flutter 2 to 1 till proven otherwise. Less than 150, it ain't PSVT. I know there are rare cases. Please, I don't want to hear about someone who's on a sodium blocker. In general, not PSVT. If it slows, not breaks, if it slows with vagal stimulation or volume, it's called sinus tachycardia. Irregular PSVT has another name now. That article that Amal showed you about new nomenclature, it's called atrial fibrillation now. Irregular PSVT, atrial fibrillation. And if you really want to screw with your cardiologist, say, I believe it's atrial fibrillation. They'll seize. All right. If someone has a history of atrial fib, atrial flutter, or MAT, they probably have atrial fib, atrial flutter, or MAT. If they have a history of heart failure or COPD, they got one of those rhythms. It ain't PSVT until you prove it. Adenosine is benign, but periodically it kills people. It kills 2 groups of people. And I will tell you that one of the groups that I've just shown you, and we're going to do the second one right now, the first group of people it kills are people with sinus tach who are barely compensated. These are often patients from the nursing home. They often have pneumonia, sepsis, fever, dehydration. Be careful. Now the second group. This used to be the second group. In the old days, you could give adenosine to wide complex monomorphic tachycardia. Then, based on using the Hubble telescope's newer lens, they realized that that was dangerous. They stopped. You can use it again. After that last launch, you can now use adenosine for this rhythm. But please remember, it is recommended to differentiate, I should highlight this word, monomorphic, which is a big word meaning all the beats look the same. If all the beats that are wide look the same, giddy up as far as adenosine to differentiate it between PSVT 15% of the time and VTAC. It won't hurt VTAC. And in fact, that last patient that I showed you, this is her EKG. And you can see that she does in fact have pre-excitation, a short PR, and this person was easily converted with adenosine. If, however, you want to kill someone, someone comes into the ED, you don't like them. From the moment they come in, you don't like them. You don't like how they look. You don't like what they're wearing. You don't like their family. And you say, there's a person, they're out. Give them adenosine, because then they're out, okay? And just pray that they do not have an attorney. Adenosine is safe in monomorphic wide complex. If you have irregular, if you have funny-looking beats that aren't the same, do not give it. If they're in atrial fibrillation with aberrant conduction, you can kill them with adenosine. So the two groups of people that I want you to remember is the following. Wide and irregular, or if they have sinus tach. Be careful in those two. Atrial fibrillation with aberrant conduction, when you give the adenosine, you slow going down, you speed up going up, and all of a sudden they get this reentry and they get a heart rate of 300 and they're gone. Be careful, respect adenosine. It's for PSVT. It is not for anything else. Now, Amal is going to do ACLS, and I apologize because I have a slide or two on pulmonary emboli that I'll skim over. But I now, and many of you may have read about this, the American Heart Association has sued me. I want to do this course. They want to sell you the textbook. This is the ACLS course. If the only thing you know in VFib is shock, the results you get are pretty close to what you can get with amiodarone, lidocaine, procainamide, and a whole bunch of epi, or no epi. For VTAC shock, no. Are they stable or not? As they move unstable, electrical. As they move stable, medical. Same for PSVT. For asystole, I don't know what works for asystole. You can oxygenate them. You can try epi. Some superstitious people think epi works. I'm not sure. I'm going to talk a little bit about EMD PEA, electrical mechanical dissociation, now called pulsus electrical activity. Almost all of them die. They have irreversible PEA. Our job is to find the reversible cause. And then for heart block or bradycardia, are they symptomatic or not? That is the entire ACLS course. You can pass the test with this, and remember to give TPA for stroke. I told you all the questions. All right. So if someone is pulseless and they have this wide, slow thing, this would be called bad on the good-bad continuum. And so I want to talk a little bit about PEA in the crashing patient. VFib, shock. VTAC, stability. PEA, reversible. Your job, our job, focus on the reversible causes. The American heart has 5 H's and 5 T's, not a chance. Airway, hypoxia. B, breathing. Tension pneumothorax, C, cardiovascular, too little volume, hypovolemia, hemorrhagic shock, too much volume around the heart, tamponade, ABC, NGT, toxic metabolic, and if you only know one toxic metabolic, hyper-K. So, there are only 5 steps. If there are only 5 causes, by law, there can only be 5 steps. Step 1, oxygenate and ventilate. I used to say intubate, oxygenate, and ventilate, but oxygenate and ventilate preferably control the airway. A supraglottic airway is as good, if not better. Get IV access if they don't already have it. Step 3, look at 3. Step 3, look at 3. Look at the EKG quickly. Hyper-K? Touch them. Are they really hot or really cold? This is not as important in admitted people, but when they're hitting the ED, even you can have hypothermia in the spring, and certainly we're getting into the hyperthermia time. Assess their volume status. I'm going to talk about that momentarily as I talk about ultrasound, but that used to be, are their neck veins up or down? Do they look like they're in fluid pulmonary edema? Epi, I thought it was epi and atropine. This slide is in error, I think. And then review for all 5 causes. But now, rather than look at their volume status, we can really look. And so I go ahead and touch them. I'm looking at the EKG, and in EMD PEA, get the ultrasound probe on. Even if you don't know ultrasound, put it on. Number 1, it looks good, and people think you know what you're doing. But number 2, as an older person for whom ultrasound, what, me? Sonocytes here, I don't know if other vendors are, we've got to be at least competent at ultrasound in a cardiac arrest. Well, wait a minute, maybe there is a reason not to have, I know Amal's probably going to talk about this now that I see he's doing ACLS. I just want to say one thing. Atropine used to be good. It's not. And that's what you want to know. Atropine used to be good. In 1979, in the Journal of the American College of Emergency Physicians, a miracle occurred. Atropine was given to 11 people, 8 of whom went on to either get MDs or PhDs. But since that time, it hasn't worked. And so in the most recent study, listed here, this is a very large study, 7,000 people, about 1,500 got atropine who had PEA. It decreased long-term survival in half. And of the people that survived, it decreased neurologic functioning by half. Atropine, no benefit in asystole, dangerous in PEA. Just say no. I used to use the atropine to flush the epi. The epi doesn't work either, probably. Don't use the atropine. So let me talk about 2 things and then stop. The first is echo in the crashing patient or dying patient. There are a number of articles about it. This is now ELS. You need to have like 5, 10, 15 merit cards. Pretty soon you'll have to have an ELS card. I got ATLS, I got BCLS, I got BTLS, I got PHTLS. There's some like neonatal thing, I don't even know about it. GYN TLS, so that you can do all the smears and know every discharge. It's an emergency. You never know. All right, but anyway, it does affect about 1 in 3 trauma arrests, and it affects more than 1 in 10 medical arrests. And I didn't write the article, there are 5 possible views. Do they have tamponade? Do they have hypovolemia? Do they have pulmonary embolus? Do they have cardiogenic shock with a really boggy heart? Or could it be a pneumothorax? They have a normal view. So here is an echo. I don't know how many of you read echoes. Here's the left ventricle and the atrium. This may be a little bit too scientific. This is my level of echocardiography. That's why I'm using these. And then you go ahead and take a look. Do they have a small heart? And you can also look at their IVC. Now, we're going to talk about LV and RV collapse. In tamponade, the RV is collapsed. Remember, it is the less musculature. In tamponade, the LV is still there, but the RV is now collapsed. In contradistinction, in a pulmonary embolus, the right ventricle is having trouble pumping blood into that occluded lung. Now we have a big RV and we have LV collapse. And then here we have a normal heart, nice view. These are the way I like to do my echoes with the labels. And so just putting it on someone who's crashing. I mean, I can't read this too much, but I got 1, 2, 3. I got 4 things, and here's the 5th ventricle, and so that doesn't happen. And as soon as you see that black stuff in the cardiac one, we're looking at an effusion. For the sake of time, I'm not going to go through each echo, but I do want to say times have changed, and we now need to be able to do a fast exam. And we need to be able to look at the heart quickly and look for those key injuries. Let me just spend a minute or 2 on this and then summarize and stop. We need to know when to give lytics. And Amal really covered this nicely. I want to make 1 or 2 points and essentially repeat what he said. But also, in some centers, you may have a CT surgeon. In fact, in our hospital, our CT surgeons troll for embolectomy. They love doing it. And the only thing, the beauty of sending someone to cath is our cardiologists then bring us back a pretty picture of here, you see this is before, this is the after, the angiogram, and you go, oh, that's great. Oh, look at this, the obtuse marginal, magnificent. Unfortunately, the cardiothoracic surgeons, they go, here, look at this, and it have these like worms in there, and they're ugly, and they just pull big clot out. So I want to spend a moment on that. So there are 5 things to do. What's their blood pressure? Are they perfusing? Are they hypotensive from their PE? What is their ventilatory ability? Can they oxygenate? So obviously in someone whose blood pressure you can't maintain or O2 sat you can't maintain, who has a PE, those are the people that are going to benefit from lytics. They're hemodynamically unstable. The other 3 things is go ahead and take a look at clot burden, take a look at what's happening to that RV, and then troponin and BNP. Take a look at some enzymatic measure. Look at their clot burden, which in and of itself no longer defines, oh my God, it was a really big clot, we had to give it lytics. which should work, but maybe they don't. How much dysfunction, how much RV collapse, how much LV collapse are we looking at? How dilated is that RV? What's going on? And then do they have signs of injury? As Amal said, based on this, there were some trials. It looked like lytics might work in undifferentiated arrest. They don't. So a patient has a cardiac arrest, you give them lytics and they survive, and everyone says, it's a great call. Who are those people? Known PE that suddenly decompensates. Someone who has unexplained dyspnea and then has syncope or presyncope, especially if it's volume responsive, be thinking about those people for having a pulmonary embolus. So here are the indications or quasi-indications. Everyone agrees, PE, refractory hypotension, refractory hypoxemia, we're going with the lytic. And some people are using TNK also to get it on board, much like they've switched from TPA. But remember, it's a longer infusion with TPA, which is both good and bad. If someone has a large clot burden that's proximal, people argue in the 11 article with significant RV dysfunction and injury, especially if they're getting worse, go with the lytic or embolectomy. Cardiac arrest due to PE. And then I just want to say this. If you have a young, healthy patient with large clot burden and they have a dilated RV and you know they already have pulmonary hypertension, I'm not saying you should give the thrombolytic. I'm saying it is important for you, the patient and family, the patient's cardiologist, intensivist, pulmonologist, get a group together and you should document in the chart that it was discussed and the consensus based on risk-benefit was. But don't just say, I'm giving lytics, I'm not giving lytics. If you have a young, healthy patient, maybe someone coming back from skiing who's 23, who has a knee immobilizer, who develops unexplained dyspnea on the plane, comes in and has a huge proximal clot or a saddle embolus, talk to people, make it a shared decision. And that's someone that may benefit from embolectomy. In closing, let me say the following. The eye doesn't see what the mind doesn't know. Patients are there to screw with our heads. Be careful. Trust no one. Believe nothing. 1 milligram. No. I'm very careful. And I always sign my resident's name. 1 milligram in 1 liter at 1 cc a minute. Titrate it in, but don't give it directly. Titrate it into a river of fluid. Rock lava, please remember, clonidine and ACE inhibitors. Be careful. They look just like narcotic overdoses. PSVT, adenosine, be sure it's PSVT. Love the ultrasound. And then lastly, let me close with this quote. All important decisions are based on incomplete information. This is emergency medicine. This is emergency nursing. This is being out in the field as an EMT paramedic. The only problem is we're responsible for the decisions. Thank you very, very much.